Morning. I am Marlene Neville. I am one of the nutrition support dietitians here in Atlanta. I work at Northside Hospital. And today, and I'm also a board member, I have the pleasure of introducing one of the surgeons who I work with at Northside. Dr. Malini Soor is a board certified surgical oncologist with expertise in the surgical management of tumors of the liver, pancreas, and gastrointestinal system. After she graduated from Harvard College, she received her medical degree from Mount Sinai School of Medicine in New York City and went on to complete her general surgery internship and residency at Mount Sinai Hospital, where she was appointed the administrative chief resident of the Department of Surgery and was awarded the Arthur Afsis Senior Prize in Surgery for her outstanding commitment to her patients. Dr. Sur then completed her fellowship in complex general surgical oncology at the University of Chicago Medical Center and completed an additional fellowship in surgical ethics at the University of Chicago McLean Center for Clinical Medical Ethics. And I think that's a wonderful segue because we have an ethics talk on nutrition support later in our workshop today. Prior to joining the Atlanta Liver and Pancreas Surgical Specialist at Northside, Dr. Sur was an assistant professor of surgery at the Mount Sinai Health System in New York and also served as the chief of surgical oncology at Mount Sinai in Queens. She has many clinical interests, including hepatobiliary tumors, pancreatic cancer, neuroendocrine tumors, and gastrointestinal neoplasms, including gastric cancer, gastrointestinal stromal tumors, or GIST, and appendix tumors. She believes in delivering to her patients the care that she would want for her own family members. She feels privileged to have an immediate impact on her patients through surgery and truly strives to be able to provide answers and comfort at a time that is often marked by uncertainty and fear. And I think a really interesting thing to note, besides when she's spending time with her family, she also has recorded 2 albums. She enjoys singing and making music. So we have a true artist among us. So without further ado, Dr. Sur.
I really appreciate the honor of speaking here. Thank you, Marlene. This is a nice break and just a different pace from what I'm usually doing. Hopefully I have nothing to disclose here. So some objectives. So today we're going to try to summarize some of the aspects of preoperative nutritional optimization for the complex GI surgical patient. I wanted to discuss the impact and considerations of nutrition support interventions in the postoperative recovery period with respect to GI surgical anatomic alterations. We'll get into some of the surgeries that we perform and describing some of the long-term management of the nutritional sequelae associated with these complex GI surgical patients. Just a little bit about me. That was an amazing and flattering introduction. So I'm a complex GI and hepatobiliary pancreatic surgical oncologist. There's multiple MD training pathways for this. Obviously, to be a surgeon in the abdomen, you're doing a residency in general surgery that's 5 years, plus or minus some research time. I did a fellowship in complex general surgical oncology, but there are some other pathways. There are folks that do hepatopancreaticobiliary surgery fellowships, and there's also, sure, of course, there's also the abdominal transplant surgery programs, fellowships that there can be kind of like a Venn diagram where you can train through multiple pathways. But at the core of it, we do upper abdominal cancer surgery, which includes liver resection with or without biliary reconstruction, pancreatectomy, obviously the Whipple procedure or distal pancreatectomy, gastric surgery. Very few surgeons only do gastric surgery, but so many times these are kind of lumped in with HPB surgeons doing total gastrectomy, distal gastrectomy, or wedge resections. We often do a lot of nodal dissection work. And the last point is that we also manage peritoneal surface malignancies. So you may be familiar with the procedure I'll get into a little bit later called HIPEC or hyperthermic intraperitoneal chemotherapy and cytoreductive surgery. So why did Marlene talk to me about coming over here? Why is nutrition important to our work? As you know, malnutrition is widespread among cancer surgery patients. Some studies even citing up to 85%. And severe malnutrition, of course, increases overall risks to the patient's survival and quality of life, both in terms of postoperative morbidity, mortality, prolonged hospital stays, infectious complications, costs, and quality of life. Cancer surgery, unlike what many of my patients think when they come to my office, it's rarely an emergency. Most cancers have been there for weeks to months, many times years. And so the idea of I have a cancer, I must be thrown down to the operating room and somebody has to cut it out quickly is a little bit of an old school idea because we know now that operating on poorly optimized, malnourished patients is likely not going to go well, and it may not lead to improved cancer outcomes. So, of course, we don't want to delay things for months and months, but sometimes taking a period of a few weeks, even up to 6 to 8 weeks, if that's what's needed to kind of settle the patient and work on the patient, may be what they need best and what's going to help them the most. We have a lot of different national guidelines on our treatment algorithms for patients with advanced cancers. Most commonly, we look at the NCCN guidelines or the National Comprehensive Cancer Network guidelines, which are publicly available, and encourage everyone here to get a log on and a login and be able to access those. NCCN doesn't tell us much about the patient in front of us in terms of their nutritional status and their physiologic comorbidities. So it'll give us a guideline as to what should be the textbook next step in treatment, but unfortunately, it doesn't really leave us much room for how to, navigate the tricky complications of malnutrition. And as you know, I don't have to tell you that medical doctors receive little to no formal training in nutrition, right? I was interested to see some of those questions. I haven't gotten those questions since I was an intern. Probably they were on the AB site, back in the old days of biochemistry and things like that. But in modern clinical medicine, certainly at the residency fellowship level in practice, that's just not something that comes up that often or that we're asked to be on top of. So that's a problem. So what does that mean? We need to work with you. We need dietitians who are experienced clinically and in the basic science realm to work with us not only in the inpatient setting, as Marlene does, but also in the outpatient setting. And I'm very fortunate to work in an environment where the importance of nutritionists has been recognized. And so I actually have and I feel like a complete princess to have two dietitians that work with me in the office setting, because it's, I think, very rare across the country for cancer surgeons to be able to offer that to their patients. Thinking about our patient population, so of course, many of them are suffering just from their GI symptoms, and I'm talking about a lot of different types of tumors, but clearly we know that malignancy itself induces some chronic malnutrition. Patients often have a few months of nausea, anorexia, weight loss. In our country, delay in diagnosis is common. We've got patients that have nonspecific symptoms that are seeing maybe someone in urgent care. They get a Pepsid or a PPI and they're told to go home and call their primary care if they need more follow-up, but they might not have one, or it might take them months to get into their primary care. So unfortunately, at the time that I'm seeing someone, they've often already had sometimes 6 months, sometimes a year of symptoms that have gone kind of unrecognized or minimized, unfortunately. Patients, of course, with pancreatic head neoplasms or ampullary neoplasms are coming in with jaundice. Some have steatorrhea, pancreatic exocrine insufficiency, abdominal discomfort, abdominal pains, vomiting, or diabetes control. So you know the drill. They're coming in and they're not at their best state. And then also many times I'm meeting them either in the hospital or in the clinic setting, but they've been in the hospital being worked up. So that diagnostic phase, unfortunately, there's not a great way to optimize this, but patients are going through multiple days of NPO status, awaiting imaging procedures, And, in those in between, sometimes I tell them, okay, it's nighttime now, chug some Ensure and get ready for tomorrow morning because you're going to be NPO again for the next procedure. We also have patients with, various drains, biliary drains, PTCs, bile bags sticking out of them. Our practice, we really try not to send people home with an external biliary bag because we find that most people cannot keep up with those losses at home unless they're very, very, plugged into a outpatient dietitian and a doctor. And so we really try to internalize those drains, but this is where having, even in patients who don't have surgical options, sometimes having a surgical oncologist or hepatobiliary surgeon involved can be critical because otherwise they're getting some kind of a temporizing procedure and being discharged and told, follow up outpatient, and they're lost, they're completely lost. So we know that patients are often losing weight in the hospital when ideally they should be on their way to getting better. And then, of course, discussed in the lecture preceding mine, we have these psychosocial aspects. You have patients who have anxiety, depression, stress, being hospitalized, being diagnosed with cancer, not knowing what's next. It's a trauma. And few patients have the emotional resilience to get through that and be focused on a dietary plan. A lot of them may not have the insight that you and I do. They don't have the education level or the medical knowledge. Some of them don't have the social support. The worrisome thing to me, one of the worst prognostic factors is somebody coming to their office visit alone, right? You know that is already, I'm like, where is your spouse? Where is your child? Who's your next of kin? Why are you at this very important visit by yourself? Um, I had a patient once who drove down from Gainesville by herself. And I said, do you need my PA to drive you back home? Because she was like, 79 years old with a new diagnosis and here by herself. And you know that's going to be very tricky when it comes to meal preparation or adhering to complex plans for the day. And then, of course, we discover that some patients have attitudes about medicine and attitudes about nutrition. We have patients who kind of like their weight loss, and we're trying to say, this is not the time to look cute. Um, this is the time to pack on pounds. And they've got all sorts of shakes and smoothies and things that they're doing, and then we're having to kind of slowly say, well, that's not really in this time period what we're focused on. We have a different goal. Now, increasingly in GI cancers, we're also more complicated because we now have many cancers have a role for the word neoadjuvant or preoperative chemotherapy. So, for example, patients with pancreatic cancer are now very rarely going to upfront Whipple, going to upfront surgery, because we know that most pancreatic cancer is actually stage 4 on presentation. We're just not picking up the micrometastatic disease on their scans. We're only picking up the things that are the size of marbles, not the things that are the size of sprinkles or cells. So most patients are going to be recommended to undergo neoadjuvant or upfront chemotherapy, either with FOLFIRINOX or a secondary regimen, gemcitabine and Abraxane. Gastric cancer patients, very few patients with gastric cancer in America are going to be diagnosed with a little, tiny little thing that's early stage. Most of them are going to be locally advanced or metastatic. So even if I'm talking about getting them to gastrectomy, they're going to usually be starting with upfront chemotherapy. So now you have this added issue of you have a malnourished patient, we're planning surgery, but oh wait, how are we going to optimize their nutrition while they're undergoing chemotherapy? It sounds kind of crazy, but with the right help and right plan, we're able to do that. GI toxicity, of course, is common from the chemotherapy regimens. So now you have to throw that in: mucositis, candidiasis, loss or change in taste, which can affect patients' ability to eat, anorexia, nausea, vomiting, of course, diarrhea, especially from irinotecan. So in preparing for this talk, I got very nervous. I said, Marlene, do I need to actually know about nutrition? Because I don't want to have to lecture to dietitians about something they know more than I do about. And they reassured me that I don't. So um, I'm giving you my version of things, but you know way better than I do that, the pre-op period is the time to optimize in preparation for alterations in GI tract anatomy, glucose control, pancreatic insufficiency, which is often unrecognized, vitamin deficiencies as evidenced by our last talk, protein intake. Really, when anytime somebody has a GI issue, not otherwise specified, or we don't know what's going on, or we're in the workup period, it is never wrong to do small, frequent meals, right? It's never wrong to kind of just slow down and see if that's going to help you to pace yourself rather than thinking breakfast, lunch, and dinner, and addressing any issues with food insecurity or just not having enough. And working with our resources that we have with our navigator, or with some of the companies that have assistance programs, trying to help patients get onto the assistance program so maybe they can get a lower those drugs at a lower cost. Okay, so in the postoperative setting, of course, in the immediate postoperative recovery period, we're dealing with that acute anatomic alteration in their GI tract. Then, of course, just complications from surgery. What I do, it would be a dream if I could do what I do and we never had complications. We kind of have to just accept the fact that just statistically, in order to do these big surgeries, there is going to be a fraction. Unlike bariatric surgery, where the rate of complications is exceedingly low, in major cancer surgeries, many patients are going to have something, and we have the tools to get them through it, but we need a lot of help. So ileus, sort of common with anybody with prior surgeries or having extensive debulking type surgeries. Delayed gastric emptying, always say the stomach's very sensitive, even though stomach surgery is not necessarily the most anatomically complex. Even if you just take out the distal stomach, some patients, for whatever reason, are going to have issues just getting back onto track, even though mechanically there's no issue. Small bowel complications, small bowel obstructions, those are things we have to be worried about. Fluid collections, abscesses, leaks, things like that. Then we have, even if everything goes well, people, of course, don't like food in the hospital, and it can be very difficult even to work with our own dietary staff on what kind of a tray is appropriate for a post-Whipple patient. So we've done our own research. We've found, Marlene knows this, that we've found that actually our bone marrow transplant patients have a very specific grass versus, I don't know if I'm supposed to say this out loud, but we use our GVHD diet because it's really nice. It's high protein, low fat, and somehow the slight alterations in that compared to the standard GI soft, we've kind of found that that's a better diet, although some patients still complain because it's a little boring. And then we have patient preferences, of course, that we have to work with. So most of our patients are not going to go home on supplemental nutrition, but it is definitely something that we consider. Primarily, I think the patients who are coming in the inpatient setting, if we're doing more urgent surgery. Some patients come with a gastric outlet obstruction. We'll get into this a little later, from their primary tumor, whether it's in the pancreas or the stomach. And then we've got to make decisions. Are we going to do something surgically to fix that and then come back another day? Or are we going to put them on CPN, TPN? Sorry, still saying TPN, but are we going to put them on central nutrition, for 7 to 10 days and then just proceed to the big operation? We also have total gastrectomy patients. We're not doing routine J tubes for Whipples, but total gastrectomies, if I'm anticipating that they will be completing chemotherapy postoperatively. Again, I think there's a lot of institutional preferences here. Our preference is still for that jejunostomy tube for, kind of getting them through that recovery period, making sure after a few months that their cancer hasn't returned, they're doing better, they're done with chemo, and then pulling out in the office. J tubes have their own complications, so they're not for free, but we do kind of pick and choose. If I'm doing a robotic total gastrectomy on a patient with a minimal, bulky disease and someone I'm anticipating may not need chemotherapy, I often leave it out because adding a minimally invasive J tube can take a longer time in the operating room. I just don't think is necessarily worth it. So the main thing is, there's a critical role for the oncology-focused dietitian, in my opinion, and they can help to nutritionally risk stratify patients to help determine the risks of surgery versus non-surgical treatments. The long-term survival benefit of surgery may be outweighed by the short-term risks in the high-risk patient, if that makes any sense. So if reasonable non-surgical options exist, this might actually be preferred over high-risk surgery. And Robin and Allison are my dietitians in my office. When we see a new patient, I often say, what do you think? Are you giving me your blessing to take this person to surgery? That's how important their opinion is. I want their feedback. I want them to tell me, yes, I had a separate conversation. They're often able, they have the time, that's their role, to get into little nitty gritty details that I haven't been able to uncover because I'm focused on their cancer and their surgery and operations. There are sometimes, I've had Robin tell me, this patient I think has early dementia, and I didn't pick it up because I was busy talking to the wife so much. But then when she got to doing, the standard nutritional assessment, talking to the patient of their preferences, and she will sometimes pick on, this doesn't make sense. They're not able to, recall, what their dietary habits are, and something's amiss. So having that, second opinion is very valuable. And then, of course, assessing patients through the perioperative period. Now that we've got support with two dietitians, we've established kind of this communication. So I often, when I come to the office, say, hey, can you check in with Marlene? We have Mr. So-and-so. He's going to be going home in 2 days on his J-tube feeds. Can we make sure that we're on the same page? So when we see them in the office, which we try to do within 5 to 7 days post-op, we're going to all be be on the same page with how to manage that patient. And I think that, it's very hard, of course, to prove these facts, but I think it's common sense that this is going to help to improve our nutritional outcomes, medical, oncologic, and psychological. I think, my main line is, just because you can have a Whipple doesn't mean you should, right? Not everybody needs to have a ginormous operation just because that is technically feasible. If it's not appropriate for them, then we might actually save their life by putting them down a different pathway for their disease. So we really have to be very selective. And I think it's very important. 20 years ago, it was, you have jaundice, you have a pancreatic mass, book you for the OR, throw you down, 8 hours of surgery. And what did we see? We saw patients falling apart, having early metastases, discharged to rehab, long complicated courses. So we're trying to get away from that, not just in pancreas cancer, but in other things. Okay, so still have a lot. Keep me on track on timing, but want to just kind of now go to the fun part, I think, of what I do, and hopefully something that you don't get exposed to too often, which is, what do we do? Some of these surgeries, just as a reminder. So liver surgery, our most common reason that we're seeing patients for liver tumors that may need surgery: hepatocellular carcinoma seen in patients with cirrhosis, or hepatitis B, hepatitis C, alcohol, sometimes just fatty liver disease, and rare patients can lead to hepatocellular carcinoma. Bile duct cancer, which is very complex because it's a biliary tree, you can have bile duct cancers up in the liver, in the hilum or hilar cholangiocarcinoma, where we have to talk about doing extended hepatectomy and bile duct reconstruction, or down in the distal bile duct, which is really inside the head of the pancreas. So we're talking about a Whipple. Also see many patients now, as you know, the rates of colon cancer are going up. It's palpable. We have younger and younger patients with colorectal cancer, and they often, are presenting with stage 4 disease. In colorectal cancer, unlike pancreatic and gastric, it's actually very acceptable to talk about doing liver surgery and resecting their stage 4 metastatic disease. Of course, they have to meet criteria, but that's because many colorectal cancers can have a slower pace. We have a lot of good drugs, so we know that working together, chipping away at it, can help them live longer. And of course, we sometimes see patients with large cysts, benign diseases like hepatic adenoma and FNH, which doesn't need surgery, but we'll evaluate them. Importantly, the liver, large organ on the right upper quadrant, it's divided into the right lobe and left lobe. That's divided by the line between the gallbladder and the vena cava. The right lobe is much larger than the left lobe. It's about 2/3 to 1/3. So when we think about right hepatectomy or extended right hepatectomy, that's a much greater physiological insult to the patient than doing a left resection. Here's just the anatomy of the gallbladder coming into the bile duct as well. And the operations we do are, most commonly, I would say, are, smaller non-anatomic wedge resections, where you're really not getting near the main vascular and biliary pedicles within the liver. But for major hepatectomy, that would be a right lobe or a left lobe or extended operations. And these are just some diagrams kind of showing you what part of the liver is coming out. Here's a, kind of a specimen photo. This is a left liver resection with a intrahepatic bile duct tumor, intrahepatic cholangiocarcinoma. Patient was basically cured with this operation. And Very importantly, when we think about liver operations, we have to think about volume. So yes, you can live without a large percentage of your liver, but it depends on how much you're taking out and what the underlying quality of the liver is. So we will do a lot of work to assess, are we going to be in a situation where there's a risk of postoperative liver failure? Because postoperative liver failure is very dangerous. We don't have a solution for that. And if you can't recover from that, it is fatal. So that has to be a almost never event. And the way that we do that is being very careful about not taking out more than about 70% in normal livers, and about, not taking out more than about 50 to 60 in patients with diseased livers. Nutritional specific liver specific nutritional considerations. Um, there are guidelines on this. They're, I would say, a little bit vague. I think, it certainly is, from a society standpoint, encouraged to have nutritional prehabilitation 4 to 6 weeks before surgery, stop alcohol use. Of course, again, with patients with biliary drains, we recommend, managing the drains so that they're not going to surgery with cholangitis or dehydration. Immunonutrition, we do support immunonutrition perioperatively in our office, although the data, is not as high level as we'd like it to be. Early oral nutrition, getting patients to clears, at minimum, not NPO, so they're getting something. And if we have prolonged complications for whatever reason, then of course we do think about adding CPN pretty early in the course. Let's move to pancreatectomy. So most commonly, we're seeing patients with pancreatic cancer. The most common type of pancreatic cancer is pancreatic adenocarcinoma, but we often see patients with a different kind of tumor. Many people know about Steve Jobs. Aretha Franklin actually had pancreatic neuroendocrine tumor. Neuroendocrine tumors are more slow growing in general, but they can be managed in very similar ways. We see patients with other tumors around the ampulla. So again, distal bile duct cancer, ampullary adenocarcinomas. We see patients oftentimes with high-risk pancreatic cysts who will need surgery. Cystic lesions are very common. Most people will never have surgery, but a few of them with high-risk features will need to have surgery. And chronic pancreatitis surgery is rare these days. We have a lot of endoscopic options, but we still need to kind of know about those procedures. Lateral pancreatic jejunostomy, Robusto resection procedures, which are rare for patients who have clearly pain associated with certain findings on their scans. So reviewing the pancreatic head, neck, body, and tail anatomy. Remember, I'll kind of always describe to patients the C loop of the duodenum and the pancreas, the head of the pancreas kind of nestled into that C loop. Tail tickling the hilum of the spleen up in the left upper quadrant. In the Whipple, which is formerly called the pancreatic duodenectomy, this is the classic MD Anderson approach. 6 main steps, but essentially we're dividing the stomach, the pancreas, and the bile duct, the duodenojejunal junction, getting rid of all that off the retroperitoneum and the vessels, the SMV, SMA, and then reconstructing the GI anatomy by bringing a loop of intestine, a loop of jejunum up, and plugging in the pancreas, plugging in the bile duct, and then bringing it forward and sewing it into the stomach. The distal pancreatectomy colectomy is less of an insult because there's no reconstruction to be done. We're taking off the tail of the pancreas and the spleen, but interestingly and kind of counterintuitively, our pancreatic leak rates are actually nationally higher with distal pancreatectomy than with the Whipple procedure. So that's always something to think about. Actually, sometimes a distal pancreatectomy course can be ironically more challenging than a straightforward Whipple. So, the nutritional considerations are there. Here's some specimen photos. Sorry, it's about lunchtime, so I don't know if this might not be up your alley. Obviously, it's up my alley, so some people like it, but this is kind of just showing you the screen right is a standard Whipple procedure. If you can imagine that head of the pancreas extending into the body and the tail, that's a distal pancreatectomy, splenectomy. This is a gentleman who had a large cyst. You can see at the inferior aspect of the body of the pancreas. Our biggest issue with our pancreatic patients is recognizing exocrine pancreatic insufficiency. I cannot, kind of advertise this enough. We are just seeing that patients have florid pancreatic insufficiency and it's not recognized. I think no one's at fault. It's just something that is not recognized that often. And the classic teaching of floating oily stools, which we learned in medical school, I learned through my own experience and working with my experienced dietitians that not everybody has to have that. And that's something that was news for me. I thought that you had to have a fecal elastase test to warrant getting on enzymes. Our approach is that anybody with some of these non-specific symptoms of abdominal pain, discomfort, bloating may benefit from enzymes. And leading into surgery, leading into chemotherapy or whatever your cancer treatment's going to be, my message is we need every little bit of help that we can get. So I think the downside to a trial of enzymes is so low that, we kind of use it very liberally. And we try to initiate that if we're seeing patients in the hospital, we're adding it in the hospital. We're trying to make sure that that's added not at the very last minute, the week before surgery or after surgery, but, at the time of diagnosis. So I think this is really critical. Not only are patients not on enzymes, but oftentimes, as you know, they're underdosed. I mean, I saw a patient the other day, I didn't even know they made this, but there's a 3,000 unit capsule. That's what they were prescribed. I was like, I didn't know that you could have a dose so low, but I doubt that it's doing much, interested to hear your opinions on that. But um, we also, again, work with companies to make sure that patients can get financial assistance if they need. Sometimes we just have to explain to them the whole concept of, the deductible. And yes, it's a big bill, but you're about to have surgery or chemotherapy. You are going to meet your deductible this year. So let's not worry about what that upfront cost is. And just kind of, reminding them that this is really critical and working with them. So I think that's probably my main message on this slide. Really important to work with a dietitian on that. And of course, postoperatively, after several months, we will start a trial period to see if they can wean off of it. Um, Preoperative jaundice, again, just focus on that hospitalized period where there's a long diagnostic period. Patients will often have biliary stenting. If you're lucky enough to be able to get an endoscopic stent for your jaundice, then that means you didn't have an external drain. So that is preferable. But sometimes patients have difficult anatomy and even our advanced GI practitioners are not able to access the ampulla through their stomach and duodenum. So those patients will consult interventional radiology for a percutaneous transhepatic biliary catheter, which again, I remember being in a phase a long time ago, being very confused by all these terms, internal, external, what does it all mean? But basically internal, external just means that you have a bag on the outside, but that drain is connected all the way down through your liver, through the bile ducts into the duodenum. And that bag is really a backup. So most of your bile should flow down if the stent is open and working well. But the external bag is your backup bag. That's often in the United States the first step for a patient who's going to get a PTC, but very critical that the next step is internalization, which means now putting in a metal stent internally and getting rid of that, or at least capping that external bag so that the patients are not going home draining 600, 800, 1 liter of bile a day and just completely getting dehydrated and losing more weight. So very critical to work with the whole team on that. So again, we're using chemotherapy up front liberally. And we often, what we'll do is if we're seeing the patient, we're recommending neoadjuvant chemotherapy, my dietitian is often calling the dietitian in the oncologist's office to kind of give that sign out and report on this patient. What do you need to watch for over the next couple of weeks? So that we're not then, the last thing we want to do is meet the patient after 2 months of chemotherapy and say, oh my God, what happened? Now what are we going to do? You're a mess. Now we've got to work on building you back up. So we want to have that communication. We always tell the patient, if you need help, obviously you can call us as well. Other things I talked about a little bit before, but just that the Whipple, of course, pancreatic surgery in part has a bad name because of the leaks and fistulas. Thankfully, with good technique at high volume centers like ours, the rates of Life-threatening complications from leaks are low. The rates of leak overall is very low. In our practice, it's less than 5% for Whipple, less than 10% for distal pancreatectomy, I would say, just anecdotally. And we, do want to make sure, again, we're working on nutrition in the hospital. And if there's glucose issues, we have an inpatient endocrinologist who's wonderful. It's now increasingly hard to get inpatient endocrinology consults, but we work with the few that are seeing patients in the hospital to make sure that, there are many of our patients, if it's new onset diabetes, post-pancreatectomy, they're going home on a freestyle and they have continuous monitoring. So we're working with them on that. Let me know how I'm doing on time because I don't have a clock up here. Oh, great, perfect. So gastrectomy, we're seeing patients for gastric cancer, gastrointestinal stromal tumor, gastric neuroendocrine tumors. All the things I was taught were rare are like not rare at all. I don't know. I think it's one of the, again, benefits of being in a high volume system where we're getting a lot of referrals from a 5-hospital system is we see these things that are supposed to be rare, like on a routine basis. Surgical anatomy of the stomach. What's important here, obviously it's a big vat, but it's not just a vat. It has a function in motility and moving food forward. When I look at tumors, I'm thinking about proximity to the GE junction and proximity to the pylorus, because those are going to have anatomic considerations that are important regardless of what kind of a tumor it is. A wedge resection that has kind of minimal impact on the patient's quality of life and dietary choices, but more formal gastrectomies, total gastrectomy or distal gastrectomy certainly has more long-term nutritional impact. So for proximal gastric tumors, which are within a few centimeters of a GE junction, our typical recommendation for gastric cancer in that location is going to be a total gastrectomy. We reconstruct that with a Roux-en-Y esophagojejunostomy, so sewing the esophagus to the jejunum in a Roux-Y fashion. A little bit different from, gastric bypass surgery in that we're not making the roux as long. We're not trying to lose weight. That's not the goal. It's actually the opposite. Again, I do tend to put in genostomy tubes for high-risk patients who I think are going to have trouble getting through chemotherapy afterwards. Distal tumors, distal gastrectomy, either with the Billroth 2 gastrojejunostomy if they have a large remnant, or if they have a small pouch, then I am doing a roux just to get that to drain a little bit better and have the jejunum not be under tension when I'm sewing it to the stomach. Here's some specimen photos. I guess not that exciting, but distal stomach, kind of seeing the antrum and the pylorus there. So we're transecting the duodenum at the duodenal bulb. Total gastrectomy specimen. This one was interesting because it was a small lesion, but I asked them to do a tattoo because there was not a serosal component. And of course, gastric tattoo doesn't work that well. So you can see here kind of just the entire upper stomach became inked. And I said, well, we're just going to take it out because we don't want to deal with the risk of having to come back that we didn't find the lesion. And that was a robotic total, went very nicely. Gastric specific nutritional considerations. Some of the patients with gastric cancer, of course, are coming in partially or completely obstructed on presentation, and it really throws a wrench in the standard pathway. Again, it's not an NCCN, right? NCCN says locally advanced gastric cancer, upfront chemotherapy, but if somebody's not eating, what are we going to do? I've done it in different ways. I'm going to get to this a little bit later, but we've managed gastric outlet obstruction in a couple of different ways. You can get them on CPN, go straight to surgery if you think that their risk of having advanced disease is low. You can do a bypass and come back another day, which I've done, or in rare circumstances, you can get them through some chemotherapy first. There are also patients with, you've heard the term linitis plastica, probably in training. Leather bottle, that's the word Latin, I think, for leather bottle stomach, which is a diffuse type gastric cancer where you're like, I don't understand, there's no big mass. Why are they vomiting? What's the problem? It's because the stomach has just basically almost become petrified. It's just not propelling anything forward. So they're eating, but it's just sitting there. And that's a very difficult situation because you can't just bypass that stomach. Those are patients where you have to think about, are we going to put them on therapy, CPN? Hopefully they have a response and feel better. Or are we going to talk about, jejunostomy tubes and nutritional counseling, very important, full liquids, high, small frequent meals. Okay, distal tumors. So this is just kind of going through my algorithm. So gastric cancer, unlike many other cancers, has a tendency to spread by peritoneal kind of touching. So you think of most oftenly cancer goes to the lymph nodes, goes to the bloodstreams, it's spreading through the blood. But some cancers, gastric, ovarian, appendiceal tumors, they can spread by shedding cells throughout the peritoneal cavity. So that's very critical because in gastric cancer patients, they really almost all of them have to have a laparoscopy to help guide where are we going in the bigger picture. About 20% of patients, when I put in the scope, I'm going to find metastatic disease, and that changes our big picture planning for what do we want to do in terms of nutrition if they're obstructed. Um, and we often deal with, GI, working with them. Do we do duodenal stents? Do we do bypass? What's the best way to, we literally have this discussion almost every week because we really need the randomized study. Maybe I can meet with Emory surgeons while I'm here and we can put this trial together because duodenal stents are nice because you avoid surgery, but they're not very durable. So we are now, like, I have now a series of patients. I went back 6 months later because their duodenal stent, they had a stent placed inside their stent. And it's just at some point, it's just a little metal thing trying to prop open the stomach. It doesn't work as well as a nice bypass, but bypass is surgery. We're able to do now robotic bypasses, which go, I mean, some of these cases can be just 30 minutes, 45 minutes. So we're just kind of figuring out who's the right person to go to surgery versus getting a duodenal stent. I really try to avoid jejunostomy tubes. Sorry, I don't know if I should say that at a nutrition conference, but I try to avoid them unless it's really the best option, just because we have so many issues with tubes and the amount of emotional support it takes to manage a tube properly. Okay, I'm gonna skip through some stuff. You guys know that distal gastrectomy can lead to delayed gastric emptying. With total gastrectomy, we have to worry about initial anastomotic edema that might lead to some spit up. Managing their tube feeds, bile acid reflux. No matter how long I make the lim, sometimes see patients complaining of this. We start cholestyramine early, make sure their head of the bed is elevated. And the other thing that's interesting is, there is this concept of pancreatic asynchrony where you didn't do anything to their pancreas, but maybe somehow the pancreatic enzyme, the bolus of when those enzymes are hitting their food bolus is altered. And so we have considered adding a trial of enzymes for patients like that. And we've even done the fancy, liposomal enzymes in order to help people who have tube feeds get pancreatic enzymes as well. Long-term considerations post-gastrectomy, of course, for the vitamin deficiencies that you all know about. I'm going to skip over this because I think you guys know about this better than I do, frankly. So let's talk a little bit about hyperthermic intraperitoneal chemotherapy. I mentioned that a while ago. Not sure if you're all familiar with that. Again, getting to this concept of some tumors spread via surface spreading as opposed to through the lymph nodes or through the bloodstream. Most commonly, the tumor that I deal with that spreads like that is appendiceal low-grade tumors that make mucin. Some appendiceal adenocarcinomas also have a mucinous component, and there is some role for patients with colorectal adenocarcinoma and peritoneal metastases. And also we work with some of our gyn-onc colleagues there. Their literature is kind of up and down with the role for HIPEC. What is HIPEC? Basically, it means we're going in and we are surgically removing every spot of disease that we can see with our eyes or feel with our hands. So it can be a long, long surgery if you have a lot of disease. It can be a short surgery if you don't have a lot of disease. And then after that period, we're infusing on the table while the patient's asleep in the operating room under general anesthesia. They're getting 90 minutes, usually of a chemotherapy, usually typically mitomycin C, infused into their peritoneal cavity, into their abdomen and pelvis through these catheters with the skin closed, just allowing that chemotherapy to touch the cells that remain and provide some level of disease control. So that's an important operation just to know about a little bit. I think patients really have to have robust nutritional reserve to undergo something like that, especially if it's coupled with a long operation. You can imagine the chemotherapy can cause ileus, delayed return to bowel function. Data for HIPEC is limited. It's not level 1 data. We don't have thousands and thousands of patients to put through HIPEC trials. And so we really have to be very selective and only pick the patients that are, physiologically, nutritionally optimized to undergo something like this, especially if we're adding bowel surgery and chemotherapy. We also try to limit how many organs we're taking out. So I try to limit it to small bowel resections, maybe the right colon or a single colon anastomosis, maybe a distal gastrectomy, but I try to avoid doing total gastrectomy, pancreatectomy, things like that with HIPEC. Just a word again on palliative surgery. I think I went into this a little bit, so I won't repeat it, but just a picture of kind of when I'm talking about a palliative gastrojejunostomy, is it's just a detour. It's just bringing up a loop of bowel, leaving the tumor there and giving the food a different way to go. And the biggest thing I tell patients is that I can do the bypass, but a chronically obstructed stomach is going to be used to not moving food forward. And so delayed gastric emptying is common. They're often thinking, we're going to do the bypass, and in 2 days, I'm going to be eating hamburger and french fries. I'm like, that's not going to happen. It's going to take time, but it is a nice, durable anastomosis, and the rate of leak, rate of problems with this is pretty low. Okay, I think we're down to learning assessment. All right, so I kept it pretty straightforward, but which of the following is a possible manifestation of pancreatic exocrine insufficiency? So you have A, steatorrhea, B, weight loss, C, bloating, D, abdominal pain and flatulence, E, all of the above. How are we doing this? We're shouting out. We have any E, yes, E. Everybody knows that. So, but that's critical, I think, for less so for you guys, probably more for what I call the infantry, right? The PCPs, the NPs now. We have a lot of mid-level providers seeing patients, helping us out with their doctor shortage and seeing patients on the front line. And we got to make sure that they know that if you're seeing anybody with pancreas issues, you should be thinking about this, not waiting for the stool to float. 79-year-old male lives alone, presents with a 50-pound weight loss over the last 6 months. CT scan shows a large pancreatic head mass. What should be the next step in management? Should you A, schedule for surgery immediately, as further delay will cause the cancer to progress and metastasize? B, consult with an oncology dietitian, begin empiric pancreatic enzymes, and initiate systemic chemotherapy? C, start chemotherapy, but do not start pancreatic enzymes as the patient denies oily stools. D, transition to hospice with no further treatment measures. B. Hopefully we're getting some sense of things that we like to see and we don't like to see. All right, a 65-year-old woman, this is the last one, presents with a 3 months, a history of low appetite and 20-pound weight loss and 2 weeks of bilious emesis. Workup reveals an obstructing distal gastric cancer with suggestion of possible involved local lymph nodes on imaging. After placement of a nasogastric tube, all of the following are acceptable treatment options except A, robotic gastrojejunostomy, followed by preoperative chemotherapy, return to the OR for a distal gastrectomy another day. B, start CPN, proceed to distal gastrectomy and postoperative chemotherapy afterwards. C, percutaneous or laparoscopic jejunostomy tube to get tube feeding started, preoperative chemotherapy, come back another day for distal gastrectomy. D, proceed to chemotherapy and then surgery with no further nutrition support. D. So you get the drift. I think A, B, and C just show you that there's not a right or wrong answer. There's going to be institutional and medical, differences in how we do things. But the idea is focus on nutrition, and if you can delay surgery, delay surgery. Okay, last thing, personal note. I want to thank you for being here. I think this is reflective of how important dietitians are to our patients. This is a letter I received from a patient. I did a total gastrectomy for gastric cancer 3 years ago. He was 78, I think, at the time, and we were worried about taking this elderly gentleman to surgery. And now he's, disease-free 3 years later. So he sends me a lot of mail, which is very appreciative. So here's the label on the address, of course, my name, but who's after me? Robin, my dietitian. And I think that's very critical, and I hope reflective of how important it is that this man got through this operation, not really, yes, I did some technical work on one day, but for the most part, all the hard work of getting him through, how do I live with this new situation? How do I get through chemotherapy was done by my dietitian in my office. And so kudos to her, but I hope that this is a kind of an example of how important it is to work together in our field. And this is just a grid that I have showing the comprehensive care of the patient who has liver, pancreas, bile duct, complex GI cancers really requires all of us working together and pooling our specialty resources, our knowledge. We all have perspectives and working together to communicate. I call Marlene. I mean, anytime on the weekend, I've called her saying, what's going on? Here's my plan for this patient. Over communication. That's, I think, the motto, right? Always discuss more. Don't be silent. Ask questions. And if you have concerns, speak up. Thanks, everybody.
Do we have any, well, thank you, first of all, Dr. Sura. That was an excellent presentation. I think it helped us to understand better the surgical consequences of what takes place with this patient population. Do we have any questions for Dr. Sura? Yes. And those of you who are listening virtually, if you'd like to submit any questions, we'd like to entertain those as well.
Hi, thank you so much for speaking. I have a question about post-op delayed gastric emptying after a Whipple. At the hospital I work at, a lot of the times when they have delayed gastric emptying, the surgeon will make them NPO and we'll start them on TPN. I was just curious what you think about that and if you would do TPN over Enteral with the anastomosis.
I think it's, yeah, it's a great question. There's a lot of institutional preference that I'm not sure, I guess, what it comes from. Sometimes it has to do with, I think, GI availability and GI willingness to kind of do more complex things at a high volume. So I will say at our institution, we're pretty similar because if we feel that, most of that delayed gastric emptying, in my experience, is resolved by 6 to 8 weeks. So, it's just that balancing. Do we want to put in a tube now that's going to be short term versus obviously, to patients? I think my experience is most patients would rather do the IV at home than have a tube hanging out. There's a lot of stigma around a tube. I will tell you, when I was at the University of Chicago, our first step would be a percutaneous GJ. And, just putting in that GJ tube. I have, for some reason in our institution, there's a lot of resistance both from GI and IR, and they do lots of complicated stuff. So I don't think it's that it's hard for them. But they find that, the J limb will slip out often. And so I've just, that's been the issue, is kind of what's the team approach. Oftentimes, I don't know where you are, if that's part of it, but it's certainly a more straightforward to get the patient on CPN, especially if insurance is not an issue and they have social support to manage, all the catheters at home. That's been our preference. And of course, working still with, SIPs of insurance, things like that through that period.
Any other questions?
I've got one kind of related to the delayed gastric emptying. Do you often use metoclopramide or alvemapan post-op in those patients that you may think would be high risk for that? Before?
Yeah, we do. I mean, we basically don't use it prophylactically. But if we are finding signs of delayed gastric emptying, my personal preference is just at least to make sure, like typically I will get a scan before I'll just start Reglan, because what I don't want to do is miss a small bowel obstruction or some fluid collection or something more anatomic and just assume that it's just run-of-the-mill delayed gastric emptying. But, I just had a patient last week where, little nausea, little vomiting, got a scan just to, again, make sure, okay, there's nothing major, there's no big complication. I did see a little bit of a distended stomach with an air fluid level. That to me is a hint that that's probably what's going on. And so in those patients, we will do standing Reglan. I am cautious about, the black box warnings. I now basically counsel everybody when I'm starting Reglan that, there are these rare Parkinsonian symptoms. in my experience, I've really only seen it in older patients who probably had some predisposition to a motor issue to begin with, but I'm kind of conscious of that more often now because you just want to make sure the patient's aware of risks and benefits. And we typically will not do the Reglan for more than 2 weeks standing, unless it's a real profound, issue. Obviously, we don't have a lot of great drugs for delayed gastric emptying. It's a big issue.
I heard you say twice that in America, diagnosis usually happens later. So how is surveillance different or in other countries?
So definitely for gastric cancer, that is the case. And that's because, so in the East, Korea, Japan, China, where the rates of gastric cancer are a lot higher, you can like go to the mall and stop by at the stall and get an EGD. It's like a very, you can get an EGD at a mall. We might need to start this at some point. But it's not quite up there statistically, maybe colonoscopy, but you can't do that at the mall. But yeah, they get EGDs much more liberally, just to check for gastric cancer, and we don't. There is no screening program for gastric cancer. And so what that means is, unfortunately, as you know, that I call it again, the front line is dealing with non-specific symptoms, nausea, vomiting, abdominal pain, weight loss. It's just hard for the PCP urgent care doctor to really recognize that as being an advanced cancer, right? And I have a biased view of the world. I would scan everybody if I could, but that if I did that, we would, from a public health standpoint, that's inappropriate because we pick up lots of stuff that then we would go and biopsy and do surgery for that didn't need to have surgery. So that's the problem with that approach. Most abdominal pain is not locally advanced gastric cancer or pancreas cancer. Most abdominal pain is, I don't know, gastritis, right? Is our hamburgers and french fries problem, not cancer. So that's the tricky thing. And, my message is always that careful balance of anything that's not getting better after a visit to the doctor, after your initial evaluation, just advocate for yourselves, for your patients. Nothing should be life-threatening, life-altering, stopping you from working if it's going on for 3 to 6 months. In my mind, appropriate workup for any GI symptoms is CAT scan, EGD, colonoscopy, CAT scan with contrast. But I don't know, from a public health standpoint, I'd probably be written up for saying that.
Well, I think too, you need to look at if a patient has lost 20 plus pounds in a very short period of time. And I think
You
that's,
gotta look at the severity in
Right.
some way. And, we find patients too, they don't, they're told, oh, it's just this. And then they come back, and then when it gets worse, they think, well, I just saw a doctor. And they said it was nothing, so it's nothing. And then they don't have that, let me go back and let me see if I can get anything more done.
we do have 2 more questions.
Sure.
And the first is, do you manage PN at your clinic? And in this person's experience, it feels like there's difficulty in accepting doctors' offices in the outpatient setting. Just wanting to hear your thoughts on this.
Yes, this is an excellent, nebulous question. I don't know if Rob and Nelson are on the line, but we're not doing a lot of micromanagement. I think essentially the company is doing a lot of it. We are looking at labs. For the most part, there are very few patients that I have that are on long-term CPN in my office, and I try not to be the doctor managing that. But it is an issue. When I was at Mount Sinai in New York, we did have a team of endocrinologists, and I think just the volumes are different there, and maybe the practices are different. So we had some endocrinologists outpatient that was literally their entire practice, was managing all the patients on CPN. But it's pretty rare to find a physician like that. So yeah, we do the best that we can. If it's long-term, typically there's another medical doctor, but I find that I think the company, they're doing a lot of the management. You tell me, you know better than I do, but I think they're doing a lot of the work of looking at labs and making adjustments. They're primarily looking to us for when do we wean, when do we stop, when do we go to cyclic, so that we will help with and write the orders for that.
The last question, in patients with jejunostomy tubes, how do you manage pancreatic enzymes? At least what I have used are the capsules that make it hard to administer via the tube. And I know part of that answer to that question,
And
so
am I allowed to say the brand name?
probably not, no.
Probably not. So I don't know how to describe, I mean, it's an infusion, it's
It's a device that has the.
it's a cartridge, basically.
Cartridge.
I guess it's it's not.
It's a
liposomal, I
it's a
know the
cartridge
word,
which
I
has
know the word, but it's a cartridge that you attach
to
the
feeding
feeds, and
tube.
then basically as the feeds are going through,
It's being
it's
digested.
like it's like a lipase activating device.
Mhm.
And we recently worked with them. It's thankfully extraordinarily rare that we need to do that. Because that's, most patients with, it's just rare for people to have both of those problems.
Mhm.
So we've probably only had one or two over the last few years that really need that, cartridge. I can get you the name later. It's not liposomal. I don't know why I'm
I-
liposomal, but
Yeah,
it's like an activated
I can tell
lipase.
you.
I think that's the
Yeah.
place.
Any other questions?
Yeah.
I just wanted to ask, Dr. Sir, are you considering any, like early supplemental PN for those patients who are very malnourished, failed oral enteral? Like how early, and are you having challenges getting that started or considered? It could be supplemental or just getting it started,
Even
even
like
before,
CPN?
right?
Yeah, I mean, CPN, I guess I'm sure probably similar to your experience, it's hard to start in the outpatient setting. I don't know of a good way to do
It can
that.
be done. It can be done.
It can be.
Those people who are in home
I'll
care.
call you next time I need that. Yeah, I mean, typically, if they're that sick, I think that they need that, then they're in the hospital. So in the hospital, we definitely, yes, early CPN.
Right.
Is that what you're talking about, like for?
Yeah, on the outpatient basis, but we can talk later, but,
Yeah.
Yeah,
just
a lot of-
utilizing,
A lot of different subtypes of situations.
right,
Obviously trying the most we can just to do small paced, I don't know what you guys, I give people the Tylenol cup and just say like, take a tequila glass without the tequila. Just to give them like a physical, just use this amount.
yes,
And do that every half an hour.
I've done that
hour.
too, yep,
Or I say, some of them have children, grandkids, I'm like, use your grandkids Tylenol cup. And just do that, and we do find that most people that works, right?
right,
And so if they need something more than that, then yes, then usually they're admitted, they get CPN. Or these rare circumstances
Mhm.
where, like recently I did do a upfront bypass on a patient with gastric cancer just because she looked like she just couldn't tolerate big surgery. And then I came back and I did the gastric, and it was kind of fun because I just did, this is kind of nerdy, but I just took out this tumor that ate later stomach, but I didn't have to do the anastomosis because it was already there from her bypass. It was kind of cool. So like a staged gastrectomy. But whether or not that's better than doing a tube or doing CPN, we just don't have the data really to show. So there is a lot of individual kind of considerations.
thank you.
Can I ask one more question? Since we share facilities, what is your take in terms of doing the GJ tubes? You're placing them surgically, but then sometimes GI will place them. And I know that.
Yeah, I haven't. I mean, it comes up, because I do think it's a very useful concept.
Mhm.
And I think they're useful tubes, but yeah, we basically have not been using them because I can't convince, I think I convinced someone once to do it.
Well, I was just
Percutaneously.
wondering, like the surgical, if you actually place them during surgery versus having a GI do it pre or
Mhm.
post,
Um,
because I know they say it migrates. Yes.
right, I think I have not been, I mean, going back to do an I think that's ultimately going back to do an operative tube is just usually seems like it's not worth the operative risk.
Mhm.
So typically, you're right, like if I mean, that is an option. If I had like a post Whipple or post gastrectomy that had delayed gastric emptying, could I consider me going back and doing But, first of all, if they have an open surgery, then you're dealing with going back into a 6 weeks out. You don't want to be going back
Right.
into that belly. Maybe it's a consideration in laparoscopic robotic cases going back, but I think most of us just kind of feel like if we can just get them through a period and it's not going to be 6 months and it's going to be more like 6 weeks,
Mhm.
that we'd rather deal with,
Right.
CPN,
It's more important
although it's
pre-op.
not ideal.
It's more important preoperatively to make your impact because post-op is a little late.
It's
sometimes.
tricky, but yeah, I
Mhm.
mean, I think these are things that I wish we had the randomized data for,
Mhm.
right? To guide us as to which one is the better approach. I think for now it is very institution dependent and doctor dependent on what they have that, who's around, who's willing.
Exactly.
I don't, these are all great people that do lots of complex things, so I truly think it's that they find it difficult, and usually that means that there's a risk that it doesn't work,
Mhm. Well, thank you so much, Dr. Sur. We've really enjoyed this and thank you for everyone's questions. I think those are very important as well.
Thank you guys, have a good day.